Okay, this is going to be ATI Chapter 36, Grief, Loss, and Palliative Care. Clients experience loss in many aspects of their lives. Grief is an interemotional response. It's exhibited through thoughts, feelings, behaviors. Bereavement includes grief and mourning, which is the outward display of loss. Okay, so let's just flip down to the nursing part of that. Palliative and end-of-life care is a very important aspect of nursing care, and we always want to attempt to meet the client's physical, spiritual, emotional, and psychosocial needs. All right, so advance directives are the legal documents that direct end-of-life issues. And two examples of that are a living will, which is that the directive documents for medical treatment per the client's wishes. It's a directive that documents the medical treatment per client's wishes. That's a living will. Next is the healthcare proxy, also known as durable power of attorney for healthcare. So that's a document that appoints someone to make medical decisions when the client is no longer to do so on their behalf. So that's like when someone knows they're getting old and they might have their healthcare proxy be their son, daughter, friend, whatever. All right, so there's different types of loss. There's necessary loss, which is loss related to a change that's part of the cycle of life that's still anticipated but still can be intensely felt. This type of loss can be replaced by something different or something better. There's actual loss. That's loss of a valued person, item, status, such as loss of a job. Perceived loss, that's defined by the client and doesn't have any obvious or variable factors to others. Maturational or developmental loss, that is any loss normally expected due to the developmental processing of life. These losses are associated with normal life transitions and help to develop coping skills. So developmental or maturational, that's stuff that usually happens in the cycle of life. For example, the child might be leaving home for college, and the parents may feel that loss. There's situational loss. That's an unanticipated loss caused by an external event. So it's a special situation, such as a tornado coming and knocking your house down. And then there's anticipatory loss, which is experienced before the loss happens. So you might have a very sick client or sick parent, whoever, and you're already feeling that loss, even though they haven't actually passed yet. There is the Kubler-Ross model, which is a theory of grief. And that includes denial, anger, bargaining, depression, and acceptance, which I'm sure we've all heard before. So denial is the client having difficulty believing their terminal illness or diagnosis. They just can't believe it's happening. Oh, the doctor's wrong, the tests are wrong, they can't believe it. Anger is when the client lashes out for other people, at other people or things. Bargaining, the client negotiates for more time or a cure, like they accept that it's happening, but there might still be something they can do, they feel. Depression is when the client is overwhelmingly saddened by the inability to change the situation. And acceptance is when the client acknowledges what is happening and plans for their future by moving forward. All right, 1 second. Oh, right. Those stages of grief might not be experienced in that order, and the length of each stage may vary from person to person, situation to situation. Some factors that influence grief and coping ability: their current stage of development, gender, the type of loss, the significance of the loss, culture, ethnicity, spiritual, any prior experience with losses, situational, socioeconomical status. Things that can increase an individual's risk for dysfunctional grieving would include being exceptionally dependent upon the deceased, a person who dies unexpectedly at a young age through violence or socially unacceptable manner, so, murder, car accident, suicide, anything like that. Inadequate coping skills or lack of social supports, and lack of hope or pre-existing mental health issues such as depression or substance abuse disorder. All right, so assessment and data. Normal grief is considered uncomplicated. Emotions can be negative, such as anger, resentment, withdrawal, hopelessness, but they should change to acceptance within time. And acceptance should be evident by about 6 months after the loss. Somatic complaints can include chest pain, headaches, nausea, changes in sleep patterns, and fatigue. That is normal grief. Now, anticipatory grief. This implies the letting go of the object or person before the loss, such as terminal illness. They have the opportunity to start grieving the process before the actual loss occurs. Now, complicated grief, on the other hand, is also called unresolved or chronic grief. So that's when the person is having difficult progression through those stages that are expected. Usually the work of grief is prolonged, the manifestations are more severe, they can result in depression or exacerbate a pre-existing disorder. The client may feel suicidal, intense feelings of guilt, lower self-esteem. And then those somatic complaints like the chest pain, the nausea, all that stuff may persist for an extended period of time. Now, disenfranchised grief is grief that entails an experienced loss that cannot be publicly shared or not socially acceptable, such as suicide or abortion. All right, so some interventions that we can do: grant time for the grieving process, identify expected behaviors such as the crying, anxiety. You can name the emotion the client is feeling. So you may want to say something like, "You sound though as you are angry. Anger is a normal feeling for someone who's lost a loved one. Like, tell me how you're feeling." Use active, open-ended questions, active listening, silence when someone's mourning. Support their efforts to move on in face of the loss. Encourage building new friendships. Assess for any evidence of ineffective coping. Encourage attendance at grief support groups. Provide them with any available resources that might be good for them. Any referrals for therapy or anything like that for people who are having difficulty resolving grief. You can participate in debriefing that's provided by a professional grief or mental health counselor. Ask the client if they want any kind of spiritual advisors or anything like that, and encourage them to do that. All right, so that was grief. Now we're on to palliative care. So the nurse serves as an advocate, as we already know, and we always want to preserve dignity and self-esteem by providing palliative care at the end of life. So palliative care improves the quality of life of clients and their families facing end-of-life issues. Palliative care interventions are primarily used when caring for clients who are dying and family members who are grieving. So it's also important to assess the family. Palliative care interventions focus on the relief of the pain and any other manifestations, as well as addressing spiritual, emotional, and psychosocial aspects of their life. It can be provided by a team of physicians, nurses, social work, physical therapists, massage therapists, art, music, touch, energy therapists, OTs, PTs, chaplains. And so hospice care is a comprehensive care delivery system that can be performed in a variety of settings and implemented when the client is not expected to live longer than 6 months. So further medical care on curing the disease stops, and the focus becomes on enhancing the quality of life and supporting the client through a peaceful and dignified death. So when you want to do your assessment and data collection, you start with identifying their sources of strength and hope. Identify any desires or expectations that the family or client may have for end-of-life care. So some characteristics of discomfort: pain, anxiety, restless, nausea, vomiting, dehydration, dyspnea, diarrhea, constipation, incontinence, and inability to perform their ADLs. So some of the manifestations we've seen with approaching death would be a decreased level of consciousness, muscle relaxation of the face, labored breathing, may start with dyspnea, then apnea, then the chained Stokes respirations, or they call it the death rattle. You can let the family know that it's not painful, it's just fluid. Their hearing is not diminished. That is the last sense to go. So make sure when you're talking in the room, you're being very respectful. Touch is diminished, but client is able to feel the pressure of touch. Mucus is collecting in the large airways. They may become incontinent, mottling, or cyanosis. So that was when the skin starts to become bluer. I believe it starts in the periphery. Pupils no longer react to light. They'll have cool extremities, perspirating, decreased urine output, and inability to swallow. So for some nursing interventions that we can do, we always want to promote continuity of care and communication by limiting the assigned staff changes and assist the client and family to set priorities for the end-of-life care. So physically, we want to give priority to controlling the findings, administer medication such as morphine to manage pain, anxiety, air hunger, performing ongoing assessments to determine the effectiveness of the treatment, lowering or hiring any medications, seeing if there's any adverse effects, reposition the client to maintain airway and comfort. Want to maintain the integrity of the skin and mucous membranes, caring touch when appropriate, an environment that promotes dignity and self-esteem. So if they are becoming incontinent, you want to remove that elimination as soon as possible and maintain a clean and odor-free environment. Offer some comfortable clothing. Provide careful grooming of their hair, nails, and skin. Encourage the family members to bring in some comforting possessions to make the client feel at home. If appropriate, you can encourage the use of relaxation techniques such as guided imagery, music. Promote decision-making and food selection activities, trying to give the client as much control as possible over their care. And you want to encourage the client to perform their ADLs as able and willing to do so. All right, so that was physical care. Psychosocial. Use an interprofessional approach. So you're going to provide care and foster support for client and family. Therapeutic communication. Facilitate the understanding of information regarding disease progression and treatment choices to the client and family. Encourage the client to participate in any religious activities that can maybe give them comfort or strength if appropriate. Encourage the client to use coping mechanisms that may have worked in the past. Be sensitive to comments made in the presence of clients who are unconscious because, again, hearing is the last sensation to be lost. And especially if they wake up and you were saying something, not good. All right, so prevention of abandonment and isolation. You want to prevent the fear of them dying alone. Make your presence known by answering call lights in a timely manner and making frequent contact. Keeping them informed of their procedure and assessment times. Allow family members to stay overnight. Determine where the client's most comfortable, such as in a room close to the nurse's station. All right, so for support for the grieving family, encourage the family plans visits to promote the client's rest so they know, okay, she's not coming till 4, they can take a nap or something. Ensure that they receive the appropriate information, such as any treatment plan changes. Determine their desire to provide physical care and maintaining awareness of any possible caregiver fatigue. Educate the family on physical changes to expect as the client moves closer to death, such as those respirations, the death rattle, or the chain Stokes, Cheyenne, Cheyenne, I don't know, Stokes. And allow families to express their feelings always. All right, so after someone passes, the nurse can be responsible for some post-mortem care. And We are responsible for following federal and state laws regarding requests for organ or tissue donation, obtaining permission for an autopsy, ensuring the certification and appropriate documentation of death, and providing the after-death post-mortem care. Once that's complete, the client's family becomes the nurse's primary focus. So you always want to care for the body with respect and compassion while attending to the desires of the client and family and any of their cultural, spiritual, or social practices. Just check with their religion or any practice to make sure all of this is okay. Alright, so you want to always maintain privacy. Remove all the tubes unless organs are to be donated, or this is like a medical examiner's case. Remove all personal belongings to be given to the family. You want to cleanse and align the body supine with a pillow under the head, arms and palms of the hand down, the sheet and blanket, dentures in place, eyes closed. Fresh linens with some absorbent pads on the bed and a gown. You want to brush or comb the client's hair, replace any hair pieces they may have. Remove any excess equipment or soiled linen from the room, dim the lights, and minimize noise to keep a calm environment. So, ask the family whether they want to visit with the family, with the body, honoring any decision they may have. Clarify where the client's personal belongings should go to, if it should go down with the body or with a specific person. Same stuff if it's an infant, except you're going to swaddle the infant's body in a clean blanket, transport the infant in the nurse's arms or in an infant carrier based on facility protocol, and offer mementos of the infant, such as the cord clamp, footprints, identification bracelets, photos, a lock of hair. Offer that to the family. So after the family has viewed the body, you can apply the identification tags according to facility policy document, and always remain aware of visitor and staff sensibilities during transport. So for organ and tissue donation, recognize that the requests must be made by specifically trained personnel. Provide support and education to the family members, using any private areas for discussing things concerning donation. Be sensitive to cultural and religious influences. Maintain ventilation and cardiovascular support for any vital organ retrieval. Some autopsy situations. Typically, the provider will approach the family about performing an autopsy. The nurse's role is to answer the family members' questions and support their choices. They can be conducted to advance scientific knowledge, for example, in a med school or something, that can lead to a development of new theories or new therapies. The law can require an autopsy to be performed if death is due to homicide, suicide, accidental death, or if the death occurs within 24 hours of the hospital admission. Most facilities require that all tubes remain in place for the autopsy. Documentation and completion of forms following the state and fed laws usually is who pronounced the death at what time, any consideration for organ donation, description of any tubes or lines left in or on the body, who was notified, what decisions were made, location of the ID tags, time the body left the facility. So we also want to care for ourselves when we're grieving. So if we're caring for long-term clients, we can create personal attachments with the nurses, or with the clients and the nurse. So some coping strategies might be to go to the client's funeral if appropriate, communicate in writing to the family, attending some debriefing sessions with colleagues, using some stress management techniques, or talking to a professional counselor. So that was the chapter on grief.